Good morning. We're about to begin. If you can hear me, raise your hand. All right, that's good enough. All right, this morning, or this week, I should say, we're going to be starting the core chapters, or the core fundamental chapters: airway management, shock, and patient assessment. And this morning, we'll be looking at airway management, so that's chapter 10. Introduction. The primary component of caring for patients is ensuring that they can breathe adequately. One of the most important skills that you will acquire as an EMT is how to manage a patient's airway effectively. It's a very important skill, and it's an essential skill to be competent with when a patient is in a critical condition. You don't have an airway, nothing else matters. When the ability to breathe is disrupted, oxygen delivery to the tissues and cells is compromised. Vital organs may not function normally, and the brain tissue will begin to die within 4 to 6 minutes. Now, because a patient can start to lose brain cells within 4 to 6 minutes, our objective is to be able to assess and manage the upper airway and lower airway within 2 minutes. So within 2 to 3 minutes, you should be able to pick up what is going on and execute the most appropriate management for the patient. It's chapter 10. Oxygen reaches body tissues and cells through breathing and circulation. During inhalation, oxygen moves from the atmosphere into the lungs. That is negative pressure. Oxygen-enriched blood is pumped through the body by the heart. You must be able to locate the parts of the respiratory system and understand how the system works. So, to be able to deal with issues affecting the upper and lower airway, you need to have a solid base in the anatomy and physiology of the upper and lower airway structures. So let's review. The respiratory system is divided into the upper and lower airway. The upper airway consists of the nose, nasal passage, nasopharynx, which is the posterior portion of the nose. You have the mouth, oral passage, and oropharynx, which is the posterior portion of the mouth. You have the larynx, where the glottic opening is located. Everything above the larynx is upper airway. Everything below the larynx is lower airway. The epiglottis is a leaf-shaped cartilaginous structure that is present to prevent anything that is not air from entering the trachea. The laryngopharynx or larynx, the oropharynx, and nasopharynx forms what we refer to as the pharynx, which is a posterior portion of the throat. The main functions of the upper airway is to warm, filter, and humidify the air that we breathe in. and that process is better executed when we breathe through the nose than when we breathe through our mouths. And that's the upper airway. Below the larynx, you have the trachea, and you have cartilage that are located before we start to get to the circular cartilage. So you have a couple cartilage in the neck going down that you need to be familiar with. You have the thyroid cartilage, which is often referred to as the Adam's apple. It's open at the posterior end, more pointed at the anterior end. Just below that, you have the cricothyroid membrane, and then below that, you have the cricoid cartilage, which is the first cartilage in the trachea to form a complete ring. The trachea eventually forms the bronchus, which divides into the right and left, right and left bronchi, and the right is more straight than the left, so the left is more at a right angle. Where the bronchus splits is referred to as the carina. We have two lungs, one on the right, one on the left. The right lung has 3 lobes, the left has 2, and the lung has a membrane with an inner and outer lining. So you have the visceral pleural and the parietal pleural. The visceral is the portion of the membrane that is directly attached to the lung. The parietal pleural is attached to the thoracic cavity. The space between the lungs is referred to as the mediastinum, and that's where the heart and major blood vessels are located. Posterior to the trachea, we have the esophagus, which goes to the stomach. Right under the diaphragm, right under the lungs, we have the diaphragm, which is dome-shaped when it is relaxed. And we have the intercostal muscles. These are very important skeletal muscles to the process of breathing. The function of the lower airway is to bring air containing oxygen all the way down to the alveoli so that it can be exchanged or diffuse into the blood. And for that to occur, 3 processes must occur without any issues. Patient must be able to ventilate, there must be proper oxygenation, and then there must be good respiration. So the respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. The airway is divided into the upper and lower airways. The structures that help us breathe include the diaphragm, chest wall muscles, accessory muscles of breathing, that's muscles in the neck, and abdominal muscles. The nerves from the brain and the spinal cord to those muscles. The phrenic nerve goes to the diaphragm, intercostal nerves go to the intercostal muscles. The upper airway consists of the nose, mouth, jaw, oral cavity, pharynx, and larynx. The upper airway's main function is to warm, filter, and humidify air as it enters the body. The pharynx is a muscular tube extending from the nose and mouth to the level of the esophagus and trachea. It is composed from top to bottom of the nasopharynx oropharynx, and laryngopharynx. The nasopharynx filters out dust and small particles, warms and humidifies air as it enters the body. The oropharynx is the posterior portion of the oral cavity, the entrance for respiratory and digestive system. The epiglottis is superior to the larynx. The larynx, a complex structure formed by many independent cartilaginous structures. It marks where the upper airway ends and the lower airway begins. And within the larynx, you have some important cartilages that you need to be familiar with. So you have the thyroid cartilage, also referred to as the Adam's apple. You have the cricothyroid membrane, which is just below that. That's a surgical point in extreme circumstances to create an airway. Then below that, you have the cricoid cartilage. Go ahead if you have your hand up. I think that's Miss Kerr. Go ahead. You have a question?
Sir, can you go back to the previous diagram, please? You said
Yes.
the thyroid cartilage is also considered the Adam's apple.
Yep. Sorry. That would be the laryngeal prominence.
Okay, sir. Thank you.
All right. Where was I? The lower airway's function is to deliver oxygen to the alveoli. The lower airway includes the trachea, bronchi, and the lungs. Trachea, conduit for air entry into the lungs. It divides at the carina into the main stem bronchi, right and left. The bronchi are supported by cartilage, and the bronchi distribute oxygen to the lungs. The bronchi eventually breaks down into bronchioles and are made of smooth muscles. They dilate and constrict as oxygen passes through them. Smaller bronchioles connect to the alveoli. Oxygen is transported back to the heart and is distributed to the rest of the body. None of this is new material. This is just a review. The heart and great vessels, which include the vena cava and the aorta, are found in the thoracic cavity, and that would be in the mediastinum. Mediastinum is the space between the lungs. It contains the heart, great vessels, esophagus, trachea, major bronchi, many nerves. Now, the physiology of breathing, and we have covered this extensively. The respiratory and cardiovascular system must work together. Right? These two systems work together to ensure a constant supply of oxygen and nutrients is delivered to the cells, and they also work to remove carbon dioxide and waste products. Now, in order for air to get down to the level of the alveoli, the patient must be able to ventilate. So there are three important processes in the physiology of breathing. You have ventilation, oxygenation, and respiration. Ventilation is the mechanical action of breathing in and out. It's a physical act of moving air into and out of the lungs. It has an active phase and it has a passive phase. Active means that muscle contraction is required. Passive means the muscles relax during that phase. The inhalation phase is the active phase. The exhalation phase is the passive. During the inhalation phase, negative intrathoracic pressure is created. During the exhalation phase, positive intrathoracic pressure is created. Oxygenation is specific to the red blood cells within the body, so it is their ability to bind to oxygen molecules using their hemoglobin pigment. And they require 4 oxygen molecules to be properly oxygenated. Respiration is the actual exchange of oxygen and carbon dioxide within the lungs and the tissues of the body. So we have external respiration and internal respiration, or pulmonary respiration and cellular respiration. So ventilation, the physical act of moving air into and out of the lungs. It is active, so muscles contract during this phase, and that would be the diaphragm and intercostal muscles. The diaphragm, when it contracts, it flattens out. The intercostal muscles will pull the rib cage up and out. Inhalation continued. The lungs require the movement of the chest and supporting structures to expand. Partial pressure is the amount of gas in the air or dissolved in fluid. Oxygen and carbon dioxide both diffuses until the partial pressure in the air and blood is equal. Inspiration focuses on delivering oxygen to the alveoli. Once ventilation is adequate, then the patient will have good tidal volume. And tidal volume is the amount of air, or the volume of air that the patient breathes in to the lungs, in and out of the lungs. Now, also, there is dead space. So we need to be aware of dead space. And everybody has dead space in their lungs. And what dead space is, it is any area within the respiratory tract in which the exchange of oxygen and carbon dioxide cannot occur, and it is constant. So dead space is 150 mils. So what it means is that when we breathe in, not all of the air is reaching the alveoli. Some of that air will stop in the dead space. So when a patient is breathing adequately, when they have good chest rise, we need good chest rise to get air to the alveoli. If the patient is not able to get good chest rise, then it means that the air will stop in the dead space. So their dead space is going to expand. And remember, dead space is anywhere within the respiratory tract that the exchange of oxygen and carbon dioxide cannot occur. So if dead space starts to expand, eventually this patient is going to be in serious trouble, to the point that we as EMS providers need to create the ventilation for the patient to push air down to the alveoli. Exhalation, does not normally require muscular effort. You can see if the patient is in distress. Passive process. Diaphragm and intercostal muscles will relax during this phase. The smaller thorax compresses air into the lungs. So the diaphragm moves up. When it relaxes, the rib cage moves back down and in, and then a positive pressure is created within the chest to push the air out of the lungs. Air can enter and leave the lungs only if it travels through the trachea. That's the only place it should be traveling. If it's traveling anywhere else, it can cause problems. Regulation of ventilation involves a complex series of receptors and feedback loops. Failure to meet the body's need for oxygen may result in hypoxia. Hypoxia means low oxygen. And we went through this when we look at the physiology, that the central chemoreceptors in the brainstem, the primary stimulus to breathe, is actually responding to changes in the pH as a result of excessive levels of carbon dioxide in the blood. And that will trigger the respirations to increase. So that's a primary stimulus. But outside of that, there are patients that have chronic respiratory problems for years, and they develop chronic carbon dioxide retention. So their pH will always be in the acidic level. The central chemoreceptors cannot respond to that. So the hypoxic drive takes over that individual's ability to breathe, and they respond to low oxygen levels in the blood. That's why it is called hypoxic drive. And the chemoreceptors for the hypoxic drive are found within the carotid arteries and the arch of the aorta. Right, now oxygenation, the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. It is required for internal respiration to take place. It does not guarantee that internal respiration is taking place. Ventilation without oxygenation can occur where oxygen levels have been depleted, example mines, confined spaces. Respiration, this is the actual exchange of oxygen and carbon dioxide in the alveoli and tissues of the body. Cells take energy from nutrients through metabolism. External respiration or pulmonary respiration brings fresh air into the respiratory system and exchanges oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. Internal respiration, exchange of oxygen and carbon dioxide between the systemic circulatory system and cells. Eventually, all cells will die if deprived of oxygen. So time is critical. Time is critical when you have a critical patient. So you cannot delay assessing airway, breathing, and circulation. It must be done quickly and it must be done meticulously. So time is critical. 0 to 1 minute without proper oxygenation can cause cardiac irritability. 0 to 4 minutes, brain damage is not likely. 4 to 6 minutes without proper oxygenation, brain damage will be possible. 6 to 10 minutes, brain damage is likely and after 10 minutes without any type of oxygenation, brain damage is going to be irreversible. And this is why we have 2 to 3 minutes to do a proper assessment of the upper and lower airway. And I would tell you need to be closer to the 2 minutes. Also, this is the reason why when you're being evaluated for your lung case trauma, if you're not able to complete a primary assessment within the first 4 to 6 minutes, closer to the 4 end, then you will fail that skill station. Factors. So let's look at the pathophysiology of respiration. Factors in the nervous system. So chemoreceptors monitor the levels of oxygen, carbon dioxide, hydrogen ions, and pH of the cerebrospinal fluid. It provides feedback to the respiratory centers. Ventilation, perfusion ratio, and mismatch. Air and blood flow must be directed to the same place at the same time. We have discussed this before. This is just a review. Ventilation and perfusion must be matched. Failure to match is the cause of most abnormalities of oxygen and carbon dioxide exchange. So if there is a mismatch, gas exchange does not take place. There's a lack of O2 in the blood. CO2 is going to keep circulating within the blood, and this leads to severe hypoxemia and eventually severe hypoxia. And the pH becomes more acidic, which is not good for brain cells. Factors affecting pulmonary ventilation. Maintaining a patent airway is critical, so this is a very important skill. Intrinsic factors that can compromise the airway: infections, allergic reactions, unresponsiveness, tongue obstruction. Extrinsic factors: trauma, foreign body airway obstruction. Now, factors that can affect respiration. External factors include atmospheric pressure, the partial pressure of O2. Internal factors include pneumonia, pulmonary edema, COPD, emphysema. So anything that interferes with the exchange of oxygen and carbon dioxide in the alveoli would affect respiration. Now, circulatory compromise. Circulatory issues that can lead to respiratory problems. Trauma emergencies typically obstruct blood flow to the individual cells and tissue. So pulmonary embolism can cause issues, and that's a clot that blocks the pulmonary arteries. A simple or tension pneumothorax, which is a collapsed lungs. Open pneumothorax is also a collapsed lungs, but there is a open chest wound. Hemothorax, that's fluid, that's blood causing the lungs to collapse. Pneumothorax is air. Hemopneumothorax is a combination of air and blood causing the lungs to collapse. And we will go into further details for these conditions when we cover traumatic emergencies. Other causes: blood loss, anemia, hypovolemic shock, vasodilatory shock. So hypovolemic shock would be low blood volume or fluid volume. Vasodilatory shock would mean that the blood vessels are too dilated. All right, now the patient assessment. So we have reviewed the anatomy and physiology, and notice I said reviewed. All of you should know this like the back of your hand at this point, because you were supposed to be studying it for your exam. So that's a review. Patient assessment, recognizing adequate breathing is the first step. So we need to know what normal breathing looks like. That's the first thing. And when we look at a patient's ability to breathe, there are several things that we consider. We will look at the rate, the rhythm, the quality, and the depth. This is not new information to you at this point. The rate, how fast or slow the patient is breathing per minute. So is it fast? Is it slow? Is it normal? Is it absent? And we will count the rise and fall of the patient's chest for 30 seconds and multiply it by 2. If it is irregular, we check it for a full minute. Patient cannot be communicating with you when you're obtaining the breathing rate. So that's the breathing rate. Then we have rhythm, which is consistency. So do we see a regular pattern of chest rise? Is it a regular pattern? Is there consistency or is it irregular? Quality, when we consider quality, we're thinking about 3 things. So we're looking to see if muscles are being used to aid breathing. We're listening for abnormal sounds with and without a stethoscope. And we're looking at the position that the patient is in. Is their head bobbing? Is the patient tripoding? Is the patient unable to lie flat? And depth would be adequate chest rise. Are you able to see visible chest rise bilaterally? That's tidal volume. If you do not know what you're looking for normal breathing, then you won't be able to identify abnormal breathing. We must consistently use all of the assessment tools, not one of them. So we have to look at rate, rhythm, quality, and depth. That's how we will be able to determine if the patient has a ventilation problem, oxygenation problem, or a respiration problem. Now, if we know what is normal, anything outside of that would be considered abnormal. So normal breathing rate for an adult is 12 to 20. For a child, you're looking at 15 to 30. For an infant, 25 to 50, or it can be above 50. Right, so fewer than 12 breaths per minute for an adult is considered concerning. More than 20 breaths per minute is also a concern. A rhythm that is irregular should definitely be a red flag for you. If a patient is breathing slow, so if a patient is breathing slow, irregular, or with poor chest rise, or no chest rise, they are having serious problems with their dead space. Okay? So any patient that is breathing slow, irregular, with poor chest rise, or there is no chest rise, meaning they're not breathing any at all, this is a patient that you will have to breathe for. Are there diminished, absent, or noisy auscultated breath sounds? Is there reduced flow of expired air at the nose and mouth? Unequal or inadequate chest expansion? Is there increased effort of breathing, often referred to as labored breathing? Is the patient breathing shallow, which is the same as poor chest rise? Is the skin pale, cyanotic, cool, or moist? Is there pulling in around the ribs and clavicles? That's retraction. intercostal muscle retraction. All right, now a patient may appear to be breathing after the heart has stopped. So you have something that is referred to as agonal gasp. In layman terms, the man a gap for breathe, or the person is gapping to breathe. It's not considered breathing. So if we see it, we don't consider that breathing. You will observe it in patients in cardiac arrest. Now, the Cheyne-Stokes or Cheney-Stokes respiration. This is associated with stroke or head injury. And basically what that is, a Cheyne-Stokes breathing pattern or Cheyne-Stokes breathing pattern is the patient's breathing rate goes up, then it comes down, then it stops, goes up, comes down, stop, goes up, comes down, stop. So it is an irregular breathing pattern with consistency. So it's irregular, but you can consistently identify the irregularity. Right? It is not normal, so it cannot be considered normal, even though you can identify the irregularity. Right? So there is consistency to it, and that is associated with head injury and stroke patients. You can also see what is called ataxic respirations. Now, this is associated with serious head injury. So this is a patient with really bad head injuries. The difference between ataxic respiration and Cheyne-Stokes or Cheney-Stokes respirations is the ataxic respiration is irregular. So that means it is an irregular breathing pattern with no consistency. So you cannot identify any consistency. You will see a pause, fast, slow, pause. There's no consistency to that irregularity. So that's ataxic respirations. It's irregular. Cheyne-Stokes is irregular, but there is consistency. Now, Kussmaul respiration, you will see this type of breathing pattern in your diabetic patients, specifically a patient with type 1 diabetes. So the type 1 diabetic, this is a type 1 diabetic that is experiencing metabolic acidosis. So their body is trying to break up the acidosis in the form of carbon dioxide and water. So they present with this rapid, deep breathing pattern with an unusual scent or odor from the breath. It doesn't smell bad, it smells, well, everybody describe it differently. It smells like nail polish to me, nail polish removal. That's what it smells like to me. Some persons will describe it differently when they smell it, but it doesn't smell bad. But they're gonna have an unusual odor on the breath. So that's Kussmaul respiration. Patients with inadequate breathing needs to be treated immediately. All right, now your assessment of respiration, even though the patient may be ventilating appropriately, respiration may be compromised. So even though there is chest rise and fall, there might not be enough oxygen available. The level of consciousness and skin color are excellent indicators of respiration. Also consider oxygenation, and that's where your pulse oximetry comes in handy. And that's a machine that we put on the, or a device that we put on the finger that will measure the concentration of oxygen in the capillaries. And it should, normal should be above 95%. Anything below that is considered abnormal. If it's below 90, your patient is extremely hypoxic. If it's within the 90s, it's not that bad. However, don't get in the habit of treating numbers. So you look at what the device is telling you in terms of numbers, and you need to ensure that the patient presentation matches what the numbers are telling you. And at the end of the day, you treat the patient presentation, not numbers. So a patient can be extremely hypoxic and the pulse oximeter is giving you a normal reading. So don't get in the habit of treating numbers. All right, now opening the airway. Opening the airway. Emergency medical care begins with ensuring an open airway. Rapidly assess whether an unconscious patient has an open airway and is breathing adequately. So you approach a patient, you introduce yourself, you check for verbal stimuli, they don't respond to verbal stimuli, you check for painful stimuli. Patient doesn't respond to painful stimuli, the patient is unresponsive. Patient is unresponsive, muscles that control the tongue relax, the tongue is now in the ear passage. We need to remove it. So you position the airway quickly and you simultaneously check for the pulse at the same time. If there is breathing present, so if you position the airway simultaneously, check for a pulse, and there is chest rise when you assess breathing, you would check the breathing for rate, rhythm, quality, and depth. If you position the airway and simultaneously check for the pulse and there is no chest rise, you evaluate the pulse for rate, rhythm, and strength, and then you focus on managing the upper airway. Position the patient correctly, and the best position to effectively manage a patient's upper airway is at the head of the patient, and the patient must be in supine position. Unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. Other causes of airway obstruction include dentures, false teeth, blood, vomitus, mucus, food, other foreign objects. Now, the methods for manually positioning the airway, these are things we have touched on. So you have your head tilt chin lift and you have your jaw thrust maneuver. The head tilt chin lift maneuver will open the airway in most patients for patients who have not sustained or are not suspected of having spinal injuries. Not going to go through the steps for that technique. That's a practical situation. If you suspect a cervical spine injury, you will use the jaw thrust maneuver. The purpose of the jaw thrust maneuver is to manipulate the mandible to pull the tongue out of the ear passage without causing any shifting in the cervical spine. Once the airway has been opened, look at the chest and observe for movement. With complete airway obstruction, there will be no movement of air. Chest wall movement alone does not indicate that breathing is adequate. Even if the airway is open, the mouth may close for the cross finger technique. So there are some patients in which you may have to use your cross finger technique to create a little more space in the airway, right? To check for fluid or foreign body, or to even insert an airway adjunct. We will practice this in the skill sessions. All right, now suctioning. Once we position an airway, we need to ensure that it's clear. And to clear an airway, we have suction devices. So if there's fluid in the airway, you're gonna hear gurgling or bubbling sounds. If you're approaching a patient and you hear gurgling or bubbling sounds, or you see any signs of fluid coming out of the upper airway passage, the first thing you will do is turn the patient as a unit if there's suspected spinal injuries, or turn the head to the side if there is no spinal injury. So we do not start an assessment if we're approaching a patient and hearing gurgling sounds with LOC. We have to clear that airway first. So you don't want a patient talking with fluid in the mouth. So if you're approaching the patient and you hear gurgling sounds or bubbling sounds, the first thing is turn the patient as a unit if you suspect spinal injury, or you turn the head to the side, allow gravity to assist you, get your suction device ready to clear that ear passage. And you have different types of suctioning device. So you have your portable, you have hand operated, and you have fixed equipment essential for resuscitation. So the ambulance must have a suction unit on board. You have your portable battery operated suction device. And then you have your handheld. I'm not a fan of the handheld for adults. The smaller bulb suction for your infants can aid you, but the handheld for adults doesn't work very well based off of my experience in the field. A portable or fixed unit should have a wide bore thick wall non-kinking tubing, plastic rigid pharyngeal suction tips, and non-rigid plastic catheters. So you need rigid or Yanker tip catheters for large secretions, and the flexible or French tip catheter for minimal secretions coming from the nose. You need to suction a advanced airway. You would use a flexible. If there's limited room to manipulate the rigid suction inside the patient's airway, then you can go to your flexible. There must be a non-breakable disposable collection bottle and water supply for rinsing the tips. All right, now techniques for suctioning. You have to be familiar with the device that you're using. So the new type suctions, once you turn it on, it starts to create the vacuum pressure, and you want a vacuum pressure that is above 300 millimeters of mercury, not less than. You choose the most appropriate suction device. So if there's a large amount of secretion, you want a rigid Yanker tip catheter. If there is minimal secretions, you want a flexible French tip catheter. There are some suction devices in which you have to kink the tubing to build up pressure to create suction, right? The older types, but the new ones, once you turn it on, it will build up pressure on its own. So you have to be familiar with the device that you're using. Now, keep in mind that we're at this point about to put a device into the patient's mouth to clear it from secretions, to clear secretions from the mouth. So you need to be protecting your eyes, your nose, and your mouth. You should not be doing any type of suctioning or upper airway management without your eyes, nose, and mouth protected. So you need proper PPE. Upper airway can get messy. Now, never suction the mouth or nose for more than 15 seconds at one time for an adult, 10 seconds for children, 5 seconds for infants. So it's 15, 10, 5. If we exceed these times, it can cause hypoxia to develop. And for the younger population, if we exceed the time and go too far back into the ear passage with the suction device, we can stimulate the vagus nerve, which slows down the patient's heart rate. When patients have secretions or vomitus that cannot be suctioned easily, so there are times when the patient might have fluid in the mouth, but it's chunky. They have chunks of food inside, so it cannot be suctioned with the catheter. You're gonna have to use your gloved finger and remove that, right? And you might want to put a bite block. I can't explain that now. I'll show you what I mean by that in face-to-face. It's hard to explain without the equipment in my hand. So you're gonna use your glove finger to clear what you can clear and then suction the liquid portion. If the patient produces frothy secretions as quickly as you can suction, then we will have to alternate with the suctioning times and ensure that we're ventilating the patient for 2 minutes or oxygenating the patient for 2 minutes. So it's suction, ventilate or oxygenate for 2 minutes, then suction again. So you have to ensure that your patient don't develop hypoxia. All right, so that's suctioning. Now let's look at basic airway adjuncts. So basic airway adjuncts. A lot of people in the medical field are familiar with airway adjuncts but don't know how to use them properly. When I say don't know how to use them properly, I mean they might know to measure and put it in, but that doesn't mean that you can use a device properly. So if you don't know when a device is needed, you cannot use it properly. It doesn't make sense. You can put in an airway adjunct, but you don't know to assess a patient and determine when it is required. You need to know when it is required, and you need to understand why it is that you're using it. So basic airway adjuncts, it prevents obstruction by the tongue and allow for passage of air and oxygen to the lungs. So you have the oropharyngeal airway or oral airway, which goes into the mouth. It keeps the tongue from blocking the upper airway and make it easier to suction the oropharynx if it is necessary. And you can use it to aid you in a patient in which you might not be able to turn that patient as a unit. Now, the indication for an oral airway is important. This is something you will be tested on. So pay attention now. There are 3 things that must be present for you to use an oropharyngeal airway on your patient. If you have not assessed for these 3 things, you should not be using the airway adjunct. So you must assess before you manage. You cannot manage what you have not assessed. And this is where persons kill patients in the field. This is where EMT students fail skill station. You cannot manage what you have not assessed. Now for the OPA or oropharyngeal airway, the first thing is the patient must be unresponsive. The patient must be unresponsive. So that's one. Two, a gag reflex must be absent. So there must be no gag reflex. That's a vomiting reflex. So one, patient must be unresponsive. Two, the gag reflex must be absent. And three, the patient must have poor or no chest rise. So that's poor or no chest rise. That's the three factors. So one, unresponsive. Two, absent gag reflex. Three, poor or absent chest rise. That's what you're looking for to determine if the patient requires an oropharyngeal airway. So indication, unresponsive patients without a gag reflex and poor chest rise or no chest rise. Apneic patients being ventilated with a bag valve mask or BVM. Contraindications. Patient is conscious, you can't use it. If the patient has an intact gag reflex, should not be used as well. Right, now that's the oropharyngeal airway. Let's look at the nasopharyngeal airway or nasal airway. The nasopharyngeal airway goes into the nose. So the NPA goes into the nose, the OPA goes into the mouth. Now, indications, for the NPA, the patient must be unresponsive or semi-conscious with an intact gag reflex. So a gag reflex is present. And there must be poor chest rise. So to use the NPA, you're looking for a patient who is semi-responsive or unresponsive with a gag reflex and poor chest rise. If you have not done a proper assessment, you should not be using the device. Patient who is unable to maintain his or her own airway spontaneously. Now, semi-conscious or unconscious patients with an intact gag reflex, patients who will not tolerate an oropharyngeal airway. Contraindications. The patient has severe head injury with blood in the nose or a history of a fractured nasal bone. And the general rule is in EMS, based on the current guidelines and protocols, we do not use an NPA for a patient with a mechanism of injury. So if it's a trauma patient, we don't use NPAs. Contraindicated. All right, now maintaining the airway using the recovery position. The recovery position is used to help maintain a clear airway in an unconscious patient who is not injured and is breathing on his or her own. Won't go into the steps for the procedure. That's skills. All right, so we are at the point where we get to supplemental O2. So at this point, I'm gonna pause. So let's stop here.